Good afternoon, good morning, everyone. My name is Aarish Reddy, and I am from Lake Nona High School. And today I'll be presenting on my topic, the global impact of STEMI, or the globe against STEMI. Now, to get started, I'd like to introduce myself. I'm a high schooler in Orlando, Florida. I'm a rising junior. I'm involved in a couple nonprofits such as Liberty in North Korea, Lake Nona Indians, the American Red Cross, the American Heart Association. I compete in a couple competitions like HOSA, Science Olympiad, the Brain Bee, and I love to volunteer at the HCA Osceola Hospital, Florida Cardiology Clinics, and the Veterans Hospital. In the past, or recently, I wrote a research paper on quality improvement of STEMI, and I presented this at the Society of Academic Emergency Medicine. And I'm an avid lover of all things cardiology and cardiovascular. Just thought I'd throw in a fun fact in there for you guys. Now, to get into the global prevalence of cardiovascular disease, maybe something we're here for. Before we get into our topic today, I'd like to speak about this major prevalence. It's estimated that 1 in 3 people die of a cardiovascular disease, and 1 in 13 people have or had a cardiovascular disease. These numbers add up to an insane number. 620 million cases of varying cardiovascular diseases. It's insane number to think about, and an insane number to think about people suffering from a cardiovascular disease. Now, I'd like to continue onwards with this prevalence. So, I'd like to elaborate a little bit more on how this prevalence is affecting some nations. So, getting into the little bit of the cost. Heart disease are a leading cause of death, globally costing over $3.7 trillion to low and middle income countries alone. And countries like America, it can cost 1.7 to $2 trillion per year. And for these low and middle income countries, this 3.7 trillion is a total summative cost, but it can cost each country roughly 2% of their GDP. And while that might not sound like a big number, that 2% of their GDP is 2% of the gross domestic products for some of these entire countries. 2% of every resource this country could have is accounting towards treating cardiovascular diseases. It's an insane thing to think about. Now, I'd like to continue onwards with my topic itself. My project is focusing on STEMI-based heart attacks, or otherwise known as ST elevation myocardial infarctions, which is essentially a specific type of heart attack. It's named after how we view this heart attack arrhythmia on an EKG, and it's named after this preceding arrhythmia or the electrical behavior present here. Now, we have over 3 million cases of STEMI throughout the globe. That's an insane number to think about as well, just for one type of heart attack or one specific type. Now, the lethality of STEMI. STEMI is one of the most lethal myocardial infractions. A 30-minute delay beyond a 90-minute golden window for reperfusion we've come across for percutaneous coronary intervention, which is a primary treatment method here, increases the 1-year mortality by 7.5%. That means in 1 year, a patient has nearly a 9% chance of dying for for a 30-minute delay in getting their treatment. It's insane to think about. And now STEMI's 30-day mortality can range from 2.5 to 10% across the globe, depending on where we are. And STEMIs account for 25 to 40% of heart attacks worldwide. So they pose a significant health threat, to say little to least. Now, mortality rates vary from 5% in developed countries to over 20% in some of these lower income nations. The median time from symptom onset to hospital arrival is around 170 minutes globally, and this exceeds that 90-minute window by a large margin, and it's not providing optimal treatment. Now, this is uh pushed aside by some developing country median times because fibrinolytic therapy is often used, and this is due to lack of catheterization labs. I'll get a little bit more into why fibrinolytic therapy is used in some of these countries, which is increasing that median time, but I'll get into that a little later on. Now, long-term outages show disparity. A 5-year mortality rate ranges from 15% to high-income countries to over 40% in countries with lower economic resources. And this can be from factors like limited healthcare access, delayed diagnosis or triage in the pre-hospital settings, a lack of emergency medical systems, which can happen a lot of times in some of these middle to low income countries. And all of this can lead to poor outcomes. And I think it's important that we improve STEMI care across the globe, and it's crucial for public health. Now, my goal was to follow the AHA Mission Lifeline guidelines to create a protocol to set forth guidelines of ideal STEMI care to be executed by a pre-hospital emergency medical services. And in this case, an acting emergency medical service was Polk County Fire Rescue. So some of the protocols, just a little bit of a general overview, was a pre-activation of an EKG for incoming patients suggestive of chest pain or STEMI or any myocardial infarction. This can allow a faster calling of STEMI while still in the pre-hospital scene, which allows us to give an early alert to a cardiac catheterization lab or emergency department. Now, communication among emergency medical professionals is crucial for the optimization of techniques, especially in developing a protocol like this. And gathering feedback from hospital personnel was crucial. in our scenario, transporting to a PCI catheterization ready facility was also super critical. Now here I'm going to get a little bit more into my research and a little bit more in depth to demonstrate a little representative sample of how our protocol helps. And this figure shows under triage rates, with the green showing the possible number of balloons and red showing the number done within 90 minutes. And the blue is what we really want to focus on. You can sort of look away from the rest. The blue is under triage rates. Under triage, which is failing to call STEMI, decreased substantially from nearly 4% to less than 1% by the year 2020. So we did a great job there. And we see the effects beginning after the implementation after 2015, and we decrease to nearly, if not consistently, 0% by the years 2021 and 2022. Now, while we consider under triage, which we just defined as identifying STEMI, over triage is identifying a false positive for STEMI, or calling STEMI when STEMI doesn't actually exist. Now, our results actually showed that our guidelines worked incredibly well. We additionally showed a decrease in over triage. So neither triage rate was compromised in improving the other, as both reached below 1% by the year 2023, despite even reaching a high of 12% in the process of development. Now, to tie this all back into global health, our protocol does not function globally in its finest sense. In the sense, not everyone has reached the standard for percutaneous coronary intervention. Many countries commonly rely on fibrinolytic therapy or thrombolytic therapy. It's essentially a drug that's used to dissolve blood clots that have formed in the coronary arteries, which is causing the STEMI or the myocardial infarction. And while the main factor for considering fibrinolytic therapies for a country has been its GDP, several other reasons can occur, like the cost of developing the facilities itself, the range of the population, so that they have a lot of rural populations out and about. Would it be difficult to create facilities that all of them could reach? And it's best shown in this image. And here I made a quick demographic of comparing the GDP of all these different countries, and they easily outpopulate America. Yet in GDP, they roughly equate to America. And this is just showing a little bit of an idea of why American can dedicate funding to a harder to achieve but stronger treatment. And I'll get more into fibrinolytic therapy right now. But I'd like to first just have a look at it. You can see that a lot of these third world countries can't even equate to a full percentage when comparing to this pie chart. Now, the major idea I want to get across is that PCI is more effective in treating STEMI-based heart attacks, but it's more expensive, it's inaccessible, and due to that 90-minute window, it's harder to achieve these positive outcomes. While fibrinolytics are cost-effective, and while they're a little bit more risky, they've been the solution to treat STEMI for so long, and they have this 3-hour range, which makes it much more convenient to use, and they've been proven efficient time and time again. And I believe that we need to raise awareness for the difference between these treatments, and that fibrinolytic therapy still needs promotion in these countries. And if possible, we should develop catheterization labs wherever possible in some of these countries. Now, here are my references for my research, and they're mostly research papers, and here are the acknowledgements. I would like to quickly thank the Global Health Leaders Conference at Johns Hopkins University for this opportunity, alongside my mentor, Dr. Ganti, and the Polk County Fire Rescue Fire Department for helping me out with gathering my data. Thank you for your time, everyone. My name is Aarish, Reddy. My name is here. My email and LinkedIn are right down there. Thank you so much for your time. I hope you all have a wonderful day and a wonderful weekend.